All right. I know we have a really great program coming, so I am going to go ahead and get us started here. I see more folks coming into the room, but I think in the interest of time, knowing that we all have such limited amounts of it, let's go ahead and get started. So, welcome everyone. Thank you so much for joining us today for our public forum, Empowering Maternal Health Through Collaborative Care. I'm Katie Schubert. I'm president and CEO of the Society for Women's Health Research, or SWHR, which is a national nonprofit dedicated to advancing women's health through science, policy, and education while promoting research on sex differences to optimize women's health. And we are really pleased today to have three distinguished panelists joining us for this event. Dr. Hai Simhan, Executive Vice Chair of Obstetrical Services at UPMC, Jennifer Lenore, perinatal psychotherapist and owner of Gracefully Balanced Perinatal Counseling, and Alicia Lee, director of the MCH Collective Impact at March of Dimes. I'd also like to thank the sponsor of today's event, Johnson & Johnson, and note that SWHR maintains editorial independence and control over our program development content and work products. And as always, we are live tweeting this event, and we hope that you will join us in live tweeting as well. Use the hashtag SWHR Talks Maternal Health, which you can see in the bottom right-hand side of the screen, and you can use that on all social media channels. And so with that, I would like to turn it over to introduce SWHR's Chief Science Officer, Dr. Irene Ninye, who's moderating today's event. Irene.
Thank you, Katie, and welcome everyone. Maternal health refers to physical, psychological, and emotional well-being of a woman before, during, and after pregnancy. Women experience many different pathways to motherhood, and each woman's journey is unique, shaped by her personal health and life circumstances. Each year, there are over 5 million pregnancies and 3.5 million births in the United States. And while research in healthcare have informed many advances for maternal health over the years, the United States remains one of the leading high-income countries for maternal morbidity and mortality. In 2021, the pregnancy mortality ratio was approximately 33.2 deaths per 100,000 live births, and more than 80% of these deaths were preventable. These tragedies occur more frequently in women and infants from racial and ethnic minority populations. For example, Black, American Indian, and Alaska Native women are 3 times more likely to die a pregnancy-related death than white women. SWHR's maternal health program was founded to address disparities in healthcare access and coverage for women to improve maternal and infant health and reduce pregnancy-related morbidity and mortality. Earlier this year, SWHR convened an interdisciplinary working group of healthcare providers, researchers, patient advocates, and healthcare policy professionals to address barriers to equitable and quality care for women throughout their pregnancy journey. With the guidance of the experts in our maternal health working group, SWHR has developed a toolkit, Journey to Motherhood, a patient empowerment guide, to help women navigate their maternal health care from pre-pregnancy through pregnancy and during postpartum. This guide offers tips for interacting with healthcare providers, nutrition and preventive care, and seeking support and resources before, during, and after pregnancy. Whether you plan your pregnancy or not, there are ways you can be prepared to have a positive maternal health journey. Today, 3 members of the working group are joining us to share highlights from the roundtable and maternal health guide. Each being a different maternal health care professional, they will also shed light from their unique expertise as to how different providers can be involved in pre-pregnancy, perinatal, and postpartum care, and promote opportunities to improve patient empowerment, shared decision-making, and access to care. Following the speaker presentations, I will moderate a discussion with the panel, so we invite you to use the Q&A function to submit questions throughout the event. And so at this time, I'd like to introduce Dr. Simhan, who will share an overview of maternal health care from pre-pregnancy to postpartum. Thank you for joining us.
Thanks for having me. I'm really excited to be a part of this uh, forum, and I will, with any luck, share my slides. So I'll be talking about the care continuum of maternal health, the notion that maternal health is really women's health during this really key peri-pregnancy epoch of time, before pregnancy, during pregnancy, in the postpartum period, and interconceptional period across pregnancies, and the way to optimize health for not just pregnancy itself, but for the health of women and infants. The maternal health journey is really this continuum of time, as I just spoke about in the introduction, and it's worth talking about the epochs, the sort of categories that maternal health journey can be divided into. First, the preconception period. And when we refer to preconception healthcare, we refer to healthcare before pregnancy, with the notion that optimizing the state of health and wellness before pregnancy is not just intrinsically valuable for the health of an individual, but can improve maternal health outcomes as well. And investments in healthcare prior to pregnancy ultimately pay off, so to speak, with a lower healthcare cost because of an optimization and improvement in pregnancy outcomes as well. Prenatal period, and this one I think is intuitive to most people in this space, is the period of time during pregnancy and includes the birth period. And pregnancy itself, of course, is a good time to focus on physical health and prenatal health, but not just pregnancy health specifically, but general physical health, mental health as well, and setting the stage for optimized lifestyle practices, maintenance of lifestyle goals during pregnancy to set an excellent stage for life after birth as well. And then the postpartum period, uh, this is an epoch of time that's the largest in terms of chronology, and that's the uh, period after birth before the next pregnancy. And this offers a window into long-term health, important for surveillance, maximization of health and wellness, and address health issues that are acute as well as potentially developing over time. The individuals who are part of this healthcare team over this span of time include individuals from a variety of disciplines who provide really important service in each of these epochs of time. And members of this healthcare team include family physicians, specialists in obstetrics and gynecology, or OBGYNs. There are also subspecialty OBGYN physicians who may be required in certain instances, reproductive endocrinology and infertility specialists for those individuals who uh, uh, are either subfertile or infertile, inability to achieve pregnancy on their own. Maternal fetal medicine specialists, individuals who are expert in the complex pregnancy medical complications for mother, for fetus, or both. Non-physician healthcare providers, such as nurse practitioners and physician assistants, are critical members of the maternal healthcare team, as well as midwives and doulas. While doulas are not direct providers of healthcare, they are incredibly important members of the healthcare professional team to provide the wraparound service to be able to optimize care before, during, and after pregnancy for women and their babies. There are a variety of specific pregnancy comorbidities that contribute to common complications during pregnancy. First, before talking about specific medical problems, we know just in terms of identity groups or demographic risk factors, some women, including women over the age of 35 and women of color, are at higher risk for certain complications that occur during pregnancy. Some of those disparity data Irene presented in the introductory remarks. I'll talk a little bit about disparities as well in a slide or two. And it is not just because individuals with these identity groups or with these demographic characteristics are more likely to have comorbidities. That's true. But the disparities related to complications are sort of outsized beyond just the increased frequency and severity of medical complications. During preconception and throughout pregnancy, providers uh, ought to not just minimize the contribution of medical complications, but monitor their development and their course in order to make appropriate clinical decisions with respect to pregnancy care, birthing care, and postpartum care. Some of the more common complications that we think about that make pregnancy less safe for women and their babies include preeclampsia or other hypertensive disorders of pregnancy, gestational diabetes, maternal health condition, and in the postpartum period, the evolution of many of these into chronic hypertension. How do chronic conditions affect pregnancy outcomes? In three really important ways during pregnancy. First, they increase the risk of a variety of pregnancy complications. Chronic conditions like pregestational diabetes, chronic hypertension, and autoimmune diseases like systemic lupus erythematosus can increase the likelihood of pregnancy complications such as preeclampsia, gestational diabetes, preterm labor, low birth weight, cesarean delivery, and other important complications that influence health in the short term and long term for mothers and their babies. Chronic medical conditions also impact fetal development. Some chronic conditions themselves or the treatment of those conditions can affect fetal growth, fetal development, fetal health. So we think about things like structural birth defects, abnormalities of growth and development, or shortened gestational age as things in the developing baby that can influence the health for that baby after birth. And then third, there is an increased risk of pregnancy loss and stillbirth associated with many chronic medical conditions. We think in general, the status, the degree of control and severity of those chronic medical conditions prior to pregnancy is directly related to the likelihood that those conditions increase the risk of miscarriage, stillbirth, pregnancy loss during pregnancy. So, how does effective management improve outcomes? In five important ways. First, preconception planning. A planned pregnancy permits identification and optimal and safe management of chronic conditions to prevent or at least minimize the risk of those conditions exerting their ill effects on pregnancy. Then, during pregnancy, regular and appropriate prenatal care in terms of the frequency of care, the content of that care, and the members of the team providing that care will very much depend upon what that underlying mental or physical chronic condition is for that woman. Medication management to provide optimal care of these chronic physical and mental conditions is incredibly important, oftentimes does require medications, and specific attention to the choice of those medications and their dosing should be made with expert care to provide best safety for mother and baby. It's oftentimes a misconception that no medications are safe in pregnancy and that pregnancy does better without the management with medications, and that's just not true. Optimal management, optimal disease control oftentimes does require medications, and experts need to weigh in on that. Lifestyle modifications, healthy and balanced diet, regular exercise do play a significant role in managing these conditions before pregnancy and during pregnancy also. And nutrition and exercise recommendations are incredibly important even during pregnancy. And as I'd said before, specialized care. Some individuals with chronic medical conditions require general medical subspecialists as well as maternal fetal medicine specialists, obstetricians who specialize in complicated maternal medical conditions or fetal conditions in order to manage pregnancy most safely. This slide describes the frequency of medical conditions and mental health conditions over time. These are data from a big data set from the Swedish national birth cohort, and American data resemble this as well. What you'll see across the range, without going into detail of each of the slides, is that whether we're talking about specific mental health conditions, circulatory metabolic conditions, autoimmune or neurologic conditions, or general medical conditions, we see an increase in frequency of many of these conditions, some of them quite dramatically over time, over this epoch of time. In this slide, it's 2002 to 2018. So the importance of what I described in the earlier slides has always been true to optimize health for mothers and babies. But the frequency with which these conditions complicate pregnancy has dramatically increased over time, making this concept even more important to maintain public health and the health of individuals. And to conclude, I'm going to, in this slide, show you that on the left is an illustration of a pregnant woman and a variety of medical conditions or risk states affecting that woman during pregnancy. We've talked about that in the previous slides. In this illustration, as you go from left to right, those conditions can lead to a higher frequency of adverse pregnancy outcomes, preterm birth, gestational diabetes, preeclampsia, etc. And importantly, the risks associated with these chronic medical conditions don't end with pregnancy outcomes themselves, but ongoing risk for cardiovascular disease and metabolic disease, other important health conditions. And so this window of opportunity helps not just optimize pregnancy itself, but optimize women's health in general over the life course and make future pregnancies safer as well. So that's this illustration, I think, nicely depicts this continuum of care and why it's so important for us to have this wraparound service in our approach to optimal women's healthcare before, during, and after pregnancy. And with that, I'll conclude my remarks and I look forward to questions and discussions later. Thank you.
Thank you,
I'm, gonna,
Dr. Simon.
I'm skipping this slide for sake of time, but maybe for questions later.
Sure, if you want to, I mean, I think you have another minute or two if you want
Oh, I
to.
do?
Yep.
Oh, okay. I will do this slide then. And I just, as I previewed earlier, just with respect to disparities among individuals, pregnancy-related and infant mortality. We know that there are important differences by race, ethnicity in the United States for both women and their infants. And Irene also illustrated another example of these data earlier. And chronic medical conditions are substantially more common among individuals uh, in minority populations, minoritized populations in the United States. And the nature of the care and control of those chronic medical conditions is, on average, less effective, less well controlled. So, one of the opportunities to help narrow and ideally eliminate disparities uh, in these populations for Black people and other minoritized individuals is to appropriately address chronic medical conditions. And so the control and optimization of preconceptional and pregnancy health is a rising tide to float all boats, but also can help us directly address disparities as well. And now with that, I'll conclude my remarks. Thank you for the extra time.
Thanks. And I mean, that's some really good information and data to share. Thank you for that opening presentation. And so next, I invite Jennifer Lenore to come on screen and prep as she will discuss mental health during pregnancy and postpartum.
Hi, everyone, and welcome. I'm so glad you're joining today's conversation on maternal health, and today I'll particularly be addressing maternal mental health. And while many of us are familiar with postpartum depression, there's a whole spectrum of emotional experiences that can unfold during pregnancy and the postpartum period. So today we're going to broaden that lens together. So let's begin with a grounding truth. 1 in 5 women in the United States will experience a maternal mental health condition. That's not rare, that's common. And it's just not depression. Mood and anxiety disorders can include not only depression, but anxiety, OCD, PTSD, bipolar disorder, and psychosis. These can emerge for the first time during pregnancy or postpartum, or worsen during this vulnerable period. What many people don't realize is that mental health conditions are now one of the leading causes of maternal mortality in the United States. This means we're not just talking about emotional wellness, we're talking about survival. When we identify and support perinatal mental health early, we're not only improving quality of life, we're saving lives. When we limit the conversation to postpartum depression, we unintentionally leave a lot of parents out of the narrative and out of support. Anxiety and OCD are just as common as depression in the perinatal period. In fact, perinatal anxiety affects 15 to 20% of birthing people, often starting during pregnancy. But because it's often mistaken for normal new parent worry, it gets missed. Unwanted and intrusive thoughts, such as fears of harming the baby or something bad happening, are experienced by 70 to 90% of new mothers. These thoughts can be incredibly distressing, especially if no one talks about them. Postpartum OCD, which includes these intrusive thoughts plus compulsive behaviors or avoidance, affects an estimated 3 to 8% of birthing people, yet it's rarely screened for and often misdiagnosed. PTSD can follow a traumatic birth, a NICU stay, or even something as seemingly intangible as feeling dismissed or powerless during labor. Bipolar disorder may first emerge postpartum, which is why careful screening matters, especially before prescribing antidepressants. And importantly, PMADs can affect partners too. Up to 1 in 10 non-birthing parents experience symptoms of depression and anxiety. When we expand the narrative, we create space for more families to feel seen, validated, and supported. Because this isn't just about depression, it's about the full spectrum of emotional health during one of life's most vulnerable transitions. As previously noted, intrusive thoughts in pregnancy are common, but rarely named. What looks like just being cautious may be reassurance seeking in response to overwhelming anxiety. As providers and loved ones, we might witness these signs and still miss what they really mean. Medical complications during pregnancy don't just impact physical health, they carry a significant emotional burden as well. So for example, a diagnosis of gestational diabetes often can bring about feelings of guilt, fear of harming the baby, and anxiety around food and control. Hypertension or preeclampsia may create a sense of powerlessness, heightened fear of early delivery. And these experiences deserve clinical attention, validation, and support in addition to medical management. There are several postpartum experiences that often go unrecognized but can significantly impact mental health and functioning. So for example, some of you may have heard the term mom rage, which can be described as intense, unexpected anger. And this is something that I see a lot even in my practice. And it's common and it can be a symptom of underlying anxiety or depression. Another thing that postpartum moms might deal with is DMER, or dysphoric milk ejection reflex. It's a physiological response to letdown when mom is breastfeeding that causes sudden brief waves of sadness or anxiety, which is often mistaken for depression. And there's even things like post-weaning depression, which is a mood shift after stopping breastfeeding, which is linked to hormonal changes and often can catch parents off guard. Many mothers experience shame around these concerns until they are acknowledged and named. While mood fluctuations, disrupted sleep, and irritability can be typical during pregnancy and the postpartum period, it's important to monitor the intensity, duration, and impact of these symptoms. Persistent sadness, anxiety, fatigue, poor concentration, and a loss of interest in daily activities may indicate a perinatal mood or anxiety disorder. Early recognition and timely referrals to appropriate care can significantly reduce risks and improve outcomes for both parents and their babies. So let's talk a little bit about the impact of untreated perinatal mood and anxiety disorders. Untreated PMATs don't just affect the parent. They have a ripple effect that can impact the entire family system. For the birthing parent, untreated PMATs are linked to an increased risk of developing chronic depression or anxiety beyond the perinatal period, making recovery more complex and prolonged. They can also interfere with bonding and attachment, which isn't about love or desire, but about the parent's emotional availability. This can lead to difficulty reading baby cues, feeling connected, or responding with confidence. There are also physical health risks. Untreated PMATs have been associated with preterm birth and low birth weight, likely due to increased stress and hormones and reduced prenatal care engagement. After birth, parents may struggle with feeding challenges, sleep disruptions, and difficulty establishing routines, all of which can affect infant development. We also see an increase in emergency room visits and pediatric concerns, as unaddressed mental health may impact a parent's ability to consistently assess and respond to their baby's needs. And the effects can extend into childhood. There's a higher risk of developmental delays, behavioral concerns, and even mood disorders in children later in life. So the takeaway is pretty clear. Addressing PMATs early is not just a maternal health issue, it's a family health issue. And treatment and prevention can change the trajectories for many families. So how do we kind of determine if a birthing person is struggling with mood? So validated screening tools help providers catch signs of distress early. The EPDS, or Edinburgh Depression Scale, is one of the most commonly used and well-validated tools for postpartum depression. For anxiety, there's the GAD-7 or PASS, which can be a bit more sensitive. And these tools are quick, free, and effective, but only if they're used consistently. Ideally, mental health screening should happen at least once per trimester at the postpartum visit as well. The American Academy of Pediatrics also recommends screening birthing parents during infant well visits. PMATs don't follow a schedule. They can surface any time in the perinatal year, so single check-ins aren't enough. And when we talk about treatment for perinatal mood and anxiety disorders, treatment should be collaborative and person-centered. Therapy is often the first line. Medications are also safe and effective for many perinatal clients, especially when coordinated with OB care. Peer support, such as support groups, is a powerful yet underutilized piece of recovery. Holistic treatment means addressing biology, behavior, and belonging. So building a community of support. Pre-pregnancy can be an opportunity for women and their community of support to plan for key prenatal pregnancy healthcare visits. Support during the perinatal period can make all the difference. There are both peer and professional resources available to help mothers feel seen, heard, and held through the journey of new parenthood. Mothers can ask their OB or hospital social workers about perinatal support programs in the area, and these professionals often have excellent referrals for therapy, groups, as well as case management. And then there's organizations like Postpartum Support International, who has lots of free support groups online, as well as a helpline, as well as a provider directory where you can find therapists, psychiatrists, and other care professionals. And so our job is to remind moms, especially during this crucial time, that self-care isn't selfish, it's survival. So we should be encouraging parents to tend to their own needs, support their healing, as we know that it protects their mental health, and help them stay connected to who they are beyond motherhood. Even small acts of care build the resilience they need to show up for both themselves and their babies. And when we talk about self-care, it doesn't have to be anything big. It is any action that is taken to care for your physical, emotional, and mental, spiritual needs, even the small things. So creating a calming playlist, or maybe it's listening to a favorite song or smelling a favorite scent, anything that kind of feeds your soul and nourishes you. And so as we wrap up today's conversation, or at least my portion of it, I want to thank you for being part of this important dialogue. Perinatal mental health is complex, it's multifaceted, and it's deeply personal. So whether you're a provider, parent, or support person, your awareness and willingness to engage in this topic makes a difference. Thank you so much for your time.
Thank you, Jen. I really appreciate, we'll get into the discussion later about, that I know we're used to the postpartum aspect of mental health, but that perinatal and during pregnancy portion, that's really important. I'm glad you were able to highlight that. And so I do want to remind all of those that are online um, live that you can submit questions at any time during using the Q&A function, and we will try to address as many as we can during the panel discussion part of the event. And so now we will have Alicia Lee to discuss how women and their providers can engage in shared decision making and promote maternal health.
Great. Thank you, Irene. Hello, all. It is so good to be with you this afternoon. And so, as we have heard, the definition for maternal health, it says it's the physical, the psychological, the emotional well-being of a woman before, during, and after pregnancy. And so as we think about the journey to motherhood, and as broken down in the guide that you saw earlier, we have 3 journeys that a woman takes specific to pregnancy. There are things that we know a woman can do in the preconception time that allows her to be in the best possible health before she enters pregnancy. More specifically, by talking with her healthcare provider, who uses one key question of, would you like to become pregnant in the next year? And then uses that answer to inform the next steps. It's a non-judgmental way to equally support women who want to become pregnant, those who do not, and then those who are ambivalent. And while pregnancy lasts for 40 weeks, we want the women and their families to build a postpartum support team with just as much care as she builds her birth team. But what does that look like? How can she ask questions, get some answers, and articulate her preferences? I give you 3 plans that all women should have in their hands: a birth plan, a postpartum plan, and a workplace plan. I think we're all familiar with that birth plan. It allows women to share her values and their choices about labor and delivery in advance with their providers. That planning ahead can help to simplify options as well as to prepare for realistic expectations. And by having conversations, it can also uncover potential challenges and how those may affect the birth plan. As one labor and delivery hospital administrator told me, if I know ahead of time that someone has a birth plan, I'm going to put her with a nurse who loves to support that advanced planning. Next, we're going to come to the postpartum plan. The roadmap includes all elements for both mom and for baby, appointments, organizations, everything that's needed to address that physical, the mental, and the social needs. We think specifically for mom about the 4th trimester, so those immediate 3 months after labor and delivery. Yet we know the effects of pregnancy can last beyond those 3 months. And so, for instance, if you have to go back and be treated at the hospital anytime in that first year after delivery, we want to make sure that that woman is informing everyone she encounters about that recent pregnancy. And finally, I come to the workplace plan. You've probably never heard of this. It's thanks to the March of Dimes Collective Impact Economic Independence Work Group that I have in Houston that I facilitate that they developed this tool that pregnant women and their partner can use in their workplace to navigate that pregnancy and postpartum time with respect to work. So for instance, what type of workplace accommodations, such as a water bottle or a chair, may be needed? What type of time off, either paid or unpaid, do I have access to in order to care for myself, my baby, or my partner? And when I come back to work, what pumping schedule do I anticipate needing? What type of private space do I have to pump? So the example here is the Houston Health Department has told all City of Houston police, if you are out on patrol and in your patrol car on shift and you need a place to pump, come to any Houston Health Department building and we will provide you with access to our lactation room. And so while all the amount of Googling during pregnancy can probably unearth these plans, what if these were just normalized? And what if everyone developed these plans? What if it was given at their prenatal visit? Or if their community health worker that they had working alongside them provided it, or that doula, or even their workplace benefits colleague, so that each woman had the opportunity to sit down and think about what comes next. And so that brings me to the scary words that you may have heard: shared decision making. And while that sounds fancy in its simplest form, it's really about two-way communication between the patient and the healthcare provider as they figure out together what to do next in regards to the current situation. And while babies are born every single day, we recognize the preferences and the needs of every individual are unique to them. And being able to voice those desires through the written plan, with the support of a spouse or a partner, with your doula or with a childbirth educator who's talked you through your options, you will have that support during the pregnancy, birth, and that postpartum time that you're wanting to have. And so while I've given a few tools for what that shared decision making could look like, let's talk about what it could look like if the pregnant woman is given all the information and resources that she needs to know in order to make that informed decision. It could be that the hospital provides free childbirth education classes to the community. We know the time a physician spends with a pregnant woman is limited, and yet the time that her support person, that they can spend with a health educator, learning, asking questions, receiving advice from the group and others, that is priceless to her knowledge growth. What if our providers used a group prenatal care model? That prenatal care is given in a group setting and allows the pregnant woman with another group of pregnant women to literally have care together. They learn from each other and they have a safe place to ask questions that most likely the person next to you also has that same question, and it helps to contribute to that feeling of safety. And as one recently delivered woman said to me, you as a healthcare provider, you do this every single day. But for me, this is my first time. Can you take 5 minutes, just talk to me a little bit about the next step? Can you provide me with some options? At the time she was in the neonatal intensive care unit, her baby was being given a bath. And while she recognized that she herself could not give the actual bath, she wanted to know what were her options to help. And that she said, can you let me hold the bowl of water so that I can participate in bathing my child? And lastly, I'm going to touch on community-based organizations, the riches that they provide, not only in terms of services, but also in the people who work for them. They want to serve the community. They want to be the resource that you didn't know that you needed. And they want to work with our hospitals. So as hospitals build community partnerships, you only have to seek out those who are in your own backyard who want to care for their neighbors and provide that support. For all of my quality improvement folks who want to have some evidence-based shared decision-making tools, I'm going to provide you with some. I'm looking at Team Birth, which is the one on the far left-hand side, and it showcases what the board looks like in the patient's room during labor and delivery. This one is specific for labor and delivery. The other two that you see on here, SHARE, which is from the Agency for Healthcare Research and Quality, as well as the AIDIT framework. These are structured communications that allow a healthcare professional to engage in a measured way with their patients. At the core of all of them, though, it's that two-way communication. It's designed for individualized, positive experience to keep patients informed of what's currently happening, what could come next, and at the same time, it allows patients the ability and the opportunity to be at the center of their care. And for me, when I look at these, the introduction of who you are by name and the names of those who are also going to be caring for me, I think it's an important step that sometimes just gets missed in the busyness of it all. I might be biased because I live in Texas and it's the pseudo South where friendliness is always the name of the game, but I'd really want to know what I can call you rather than just saying, hey, you. So, in closing, I'm going to ask you to be curious, not judgmental, about the story that each individual brings. That woman has assembled her village of support for her pregnancy. She has her support people. She has her physician or her midwife. Perhaps she has a care navigator, a doula, someone who's walking alongside her and providing education. And she's asking to have the best possible outcome for herself and her baby. And so these are the resources that I shared if you're interested in accessing any of them and the links that were included. And thank you to the Society for Women's Health Research for allowing me the opportunity to share stories of those people that I get to work with every single day as we build a better community for healthy moms and strong babies.
Thank you so much, Alicia, and everyone for setting the stage for this panel discussion for the remainder of this event. Again, we invite attendees to submit questions using the Q&A function within the webinar app, and we'll try to address as many questions as we can during the remaining 10 to 15 minutes of the program. And at this time, I invite Jen and Hai to turn on their cameras. Please note that our conversation today is intended for educational purposes and is not intended or implied to serve as a substitute for medical or professional advice. We encourage all patients and their supporters to confirm information and consult with their healthcare providers to determine their individual needs. So to open up this conversation, we know the healthcare ecosystem is vast and it's very complex. Providers and services are located all over your city and your state. Insurance covers some things and maybe not others. It can be very overwhelming. But there are so many untapped opportunities that we can identify and expand and even promote different solutions in this public health crisis that we experience in the US for maternal morbidity and mortality. And so I'm going to throw it to you, High, first. So, and because there's some recent developments, so guidance in maternal health care recommends about 12 to 14 visits for lower average risk pregnancies. And then there's imaging and ultrasounds and some blood work. But recently, ACOG, the American College for Obstetricians and Gynecologists, has released updated guidance that promotes flexibility and considering individual needs to adjust the mode or the frequency of appointments. And so can you maybe give us a 90-second overview of what this means for women and their providers?
I think it's a really great question and an important sort of sea change in our approach to prenatal care. Prenatal care largely has been a one size fits all in terms of recommendation, uh, but in practice has turned out to not be that way. It's been very intensive for some individuals and less so for others. I think the strategy of being able to customize prenatal care depending on the intensity of someone's need, and I want to talk about mode also. That was in your question and in the new recommendations. Uh, the old model of traveling to some location, having a face-to-face visit, and the content of the visit may be very, very brief, but the episode of care may be long in terms of travel and time missed for work. Technologies allow us to be able to provide telehealth services that are live and synchronous, but also population health approaches using secure messaging and monitoring of things like blood pressures and blood sugars really give us a lot of flexibility to be able to deliver care for women without uh, unnecessarily increasing the burden of receiving that care. And so I'm really grateful that ACOG and other professional societies have uh, made this a part of the recommendation. And I think it's up to us in institutionalized obstetrical care to be able to respond to those and deliver that flexibility of care, face to face, live synchronous, or remote monitoring as needed. It's a really, really nice change.
Thanks. And kind of to follow with that, Alicia, you mentioned we have all these different modes, and you had talked about the shared decision making and what that practically might look like. Because I'd imagine even in this scenario, you have to have conversations with the moms and moms to be about what works, right? What challenges they might be experiencing. But what recommendations or advice do you have for women who might feel misunderstood or dismissed by their doctors? So if I have these challenges, I'm expressing them, but they're not working with me, what advice do you have for them?
Sure. So that's a great question because we know that the research has shown us that about 1 in 8 women feel during the labor and delivery episode, they feel that they've been dismissed or that they have felt unheard or they've experienced something that isn't quite what they would think of as right. And so we know, again, specifically in a labor and delivery in a hospital setting, there are patient advocates that the hospital has that you can talk to. So pick up the phone in your room and ask to talk to a patient advocate or have the patient advocate come to your room. We also recognize that your partner, your support person that you have there, they are someone that you can talk through, you can talk with, as well as we know that there are others who are willing to talk through a conversation with you, such as a doula. They're not necessarily going to speak for you, though. They'll provide you with options. It's why I love our community health workers when you're in a clinical setting because they'll spend time with you. They'll talk to you about if you have questions, you can sit down with them virtually while you're there in person for a visit and you can talk through, hey, what does this mean? And if needed, they can then say, I think, this is not medical advice, but you should then write down your questions and go ask your physician and your physician's team about them again. So really, I say a pen and a piece of paper or your phone and the notepad in your phone. It's sometimes the best thing that you can bring to your appointments.
That's really good. And I guess more of a comment or a piece, but I know you mentioned some resources that individuals can do for like lactation support in the community and all of that. And so I will follow up with our panel for those that are watching. And when we do the recording and we release the recording of today's webinar, we'll include that in the email for folks so that they can have those links readily accessible. Jen, I want to come to you because as we talk about these conversations and challenges individuals are having, and you mentioned a lot of the mental health concerns are not just postpartum, but they can also start during pregnancy. But it's not, and I feel like in a conversation we might have had before, it's not just about the mom. So um, pregnancy related mental health period, involves a family. And you talked a lot about the family. And so, how can we engage our support system, our partners, and the children that are also affected, in the home when we have some challenges with mental health?
Thank you for that question, Irene. What I find incredibly helpful is engaging the family during the pregnancy to provide education even beforehand about any mental health disturbances or concerns, signs, symptoms, what to look for. I find a lot of times these conversations happen once the mood disturbance has already occurred and it's already had a significant impact. It's thrown everyone for kind of a bit of a curveball, if you will. So I think early conversations just to kind of minimize the taboo, we don't talk about that, trying to really move away from that, having these really having families participate in the education, again in the hospital after mom delivers, having the family participate in those conversations. And I think it's even helpful utilizing resources that families might already be tapped into. So for example, if I have a couple who's already maybe in couples counseling, right, talking about the relationship dynamics and how that shifts when a baby is born, right? It's not always necessarily depression or anxiety. It's just sometimes it's relational type things. We hear a lot about moms talking about being maybe a default parent or carrying the mental load. So I think tapping into resources that already exist, educating early, and also really partnering with providers like pediatricians. A lot of times the conversation is centered solely on maybe baby's development and milestones, but if pediatricians are even comfortable, just talking a little bit about how mom is coping, adjusting, what they're noticing, and getting them linked in and connected to care can be really helpful.
Thank you. And I want to ask Hi a combination. We've gotten a couple of things about, and you've talked about it. How do we know um, when there's a challenge? So many changes are happening during pregnancy. There's weight gain, fatigue, like you mentioned, the disordered sleep maybe, and all of that. But, what about how do I know if am developing a thyroid Hashimoto's, right? Thyroid disorder, or how do I know that I have preeclampsia or that it's diabetes or something like that? What steps can or what warning signs should individuals be looking out for, and for the doctors that they might be engaging other spaces that aren't in the maternal health space? What types of advice would you give for them to look out for to make sure that we're catching things early?
It's a really important topic. It's quite broad because it covers lots of health conditions. And a couple points to make. One is, uh, first, it can be hard for people to distinguish uh, those things that are uh, symptoms that accompany pregnancy or evolve over pregnancy from those things that are abnormal or an indicator of an obstetric problem or a medical problem. That's quite hard for someone to identify themselves. Uh, in general, what I generally advise is if something has a change in trajectory that's rapid onset, sort of suddenly, or it feels severe. So that could be pain or things like shortness of breath or related symptoms. Those general, things that are severe in nature or of rapid onset are customarily not part of sort of the normal or expected discomforts of pregnancy. So those would be things to bring to a healthcare professional's attention. On the provider side, it's a really important point, which is individuals who are care providers for lots of folks, not just women or not just pregnant women, uh, may be less comfortable in their ability to discern that which is pregnancy itself and that which is not. And it's pretty common for folks to think anything that happens to or in a pregnant person is because of pregnancy. And I mean, this is not true. Some things are part of normal pregnancy, other things are pregnancy complications. And so, in those instances, let's say an individual like a family medicine provider or a general internist sees a person who's pregnant with sets of symptoms. That's an example where consultation with an obstetrician, gynecologist, or a maternal fetal medicine provider is really important. And I think it's useful and for individuals like that, family medicine providers or general internists, to have a kind of network of obstetricians and a network of maternal fetal medicine providers sort of on their speed dial, so to speak, so they know with whom I can ask a question or send a patient for a referral. It's a really important bi-directional relationship for care providers to develop. It's a super great question. Thank you.
And then this is a quick one before we wrap up. Hi, well, I guess anyone, but I'm not sure if Hi, you might be the one. Pelvic floor therapy. What is a pelvic floor, and why is this important postpartum or during pregnancy or postpartum?
The pelvic floor is it okay if I answer that question? I know okay. Represents the muscles and connective tissues that are at the sort of bottom of the uh, abdomen, the abdominal wall, the back, and sit above the vagina and support the structures in the pelvis, the bladder, the vagina, the uterus, and the rectum. The pelvic floor encounters many anatomic and functional structural changes over the course of pregnancy and at the time of birth. The function of that pelvic floor and its effect on normal sexual function, the continence of urine, the continence of flatus or stool, can be affected by the course of pregnancy and by birth. Uh, and the course of recovery of normal pelvic floor function uh, is different for different women. There is healing that must happen after pregnancy and after birth for all women. And there's a normal trajectory of that recovery. And then there's an abnormal trajectory of that recovery where injury and dysfunction or abnormal function can happen. Doctors like obstetrician gynecologists, specialized OBGYNs called urogynecologists, and other healthcare professionals like pelvic floor physical therapists are incredibly important resources for evaluation and management. Some of that evaluation and management includes exercises, lifestyle modifications, includes medical therapies, and sometimes includes surgery as well as physical therapy. I'm really glad you specifically pointed that out. Maybe that's in response to a question. It's an under-recognized, underappreciated consequence of pregnancy. There are the stigma and shame associated with it, which is really, really unfortunate. Uh, there are great data to show that women don't seek care for these conditions because of those things. And the more we talk about it and destigmatize it and provide those resources, the more we can connect women to the care that they need.
That is so great. Thank you for that. And I know we're coming to our close, but before we wrap up, I have one last question. We have diverse audiences spanning patients and healthcare providers, as well as researchers, policy professionals that tune into our online events and watch them later. Can each of you share a suggestion for one solution? It can be low-hanging fruit or long-term strategy to address research, healthcare gap, or disparity for women navigating maternal health. But specifically, I know I'll pare that down. Jennifer, can you speak to healthcare providers? And then Alicia, can you speak to women and pregnant people that are watching? And then Hi, you'll close us out with speaking to families and friends of pregnant women, their support system.
Sure. And can you ask the question one more time?
So what is a suggestion or solution that you would like to offer or a word of hope? Like, what is your final thought for this audience? And so, Jen, you have the healthcare providers. Alicia, you have women and pregnant people. And then Hi, you have their family and friend supports.
I think I would say, during pregnancy, there already can be a lot of anxiety around the unknowns. Am I doing this right? Even though there are not a ton of things you might feel like you're in control in. So I think to providers, I would say to trust the birthing person and their experiences that they bring to you. Allow them to be the expert on them, right? You might have the medical perspective and expertise, but in terms of their lived experience, what they're going through, really meeting them where they are. Even if you have delivered 1,000,001 babies, it's this person's very unique, singular experience. And it's so important to keep that in mind. And so that those encounters do carry with birthing people throughout the rest of their pregnancy and delivery. And a lot of times we're going back and revisiting encounters with providers, even through that healing process. So I think just really trusting the stories that come before them and honoring those stories, holding space and acknowledging that person as an expert on them.
Yeah, so I'll build upon that. Thanks, Jen. So I would say one long-term strategy is the investment in our community care coordinators, our community navigators, a perinatal navigator, a community health worker, whatever you might call that within your system. But these are individuals who can provide you with the education to help provide you with the advocacy that you as the pregnant woman that you want to know, that they're going to be able to spend time with you. They'll be able to point you to resources that you need, whether it is those social needs for housing or food, or whether it's lactation and breastfeeding, or I'm not able to breastfeed, so where can I find formula for my baby? I really think that they are the secret that has been embedded within our healthcare system to provide that resource and that support outside of that traditional birth team that you might see.
And I'll address the family and friends question, which is really will come down to support. I think family and friends can be there to provide emotional support and be a listening ear for pregnant people, new mothers. They can provide practical support, physical help with activities of daily living, uh, organization or support of things in one's life as one, as a pregnant and postpartum person accommodates the new birth experience, providing mental health support, watching for signs of postpartum depression or anxiety, watching for things that seem unusual and being there uh, for someone in that capacity. I think it's important to do so in an informed way. And so being informed and educated on these topics is important for everyone, friends and family members as support people, even if they're not the birthing person themselves, and providing respect for boundaries uh, and privacy, physical boundaries as well as privacy boundaries. So being informed and being respectful in provision of that support.
This is all great advice. Thank you so much. Thank you for sharing your time, your insights, your transparency, and also thank you to Johnson & Johnson for their support of this event, SWHR's Maternal Health Program. Again, we cannot do this work without the expertise and contributions of our science networks, particularly the Maternal Health Working Group members who contributed to the development of the Journey to Motherhood Patient Empowerment Guide. Again, this guide features information presented today and much more, grouped by key phases of the motherhood journey, which is pre-pregnancy, pregnancy, and postpartum. It also contains a postpartum worksheet to track your symptoms and needs in the weeks following birth, so new moms can be prepared to describe their experiences during their next doctor's appointment. And so they'll drop a link in the chat with that link to the resource guide, and want to encourage everyone that understanding women's individual experiences and health journeys really helps us inform healthcare systems and policymakers on critical gaps in specific areas of need in women's health. So SWHR invites you to share your story about maternal health, fertility, or heart health, autoimmune disease, or any other women's health topic by visiting www.swhr.org/share your story. And as always, we invite you to connect with us on social media and visit our website at www.swhr.org for more information about maternal health and other topics, resources, and events, and to sign up for our newsletter. We will send out an email with a recording of today's public forum to all registrants, as well as post the recording on the event's webpage for future viewing. So please be on the lookout for that and feel free to share with others as we continue this very important conversation with hashtag SWHR Talks Maternal Health.